So I'm going to just start by some myths or comments that you hear all the time from patients, and then a little bit about sick day rules as pertain to type 2, a little bit more detail about type 1 diabetes, and then we'll just have a couple of case studies at the end just to sort of recap on some of the key points. So you'll all have heard this. I don't understand why my blood sugars are so high when I haven't eaten. And there is a perception that high blood glucose levels are to do with eating. And similarly, along the same lines, I wasn't eating, and therefore I don't need to take my medicine or my insulin. And of course, although food does have something to do with your blood glucose levels, there are other factors involved. And so when we think about sick days, we're not just talking about somebody that's sick in bed with flu, although that's part of it. So it's anything that causes that stress to the body, that causes that fight and flight response. So that's your infections, colds, flu, sore throats. But also who's is in pain or has an injury, might have had some surgery or dental work. And the other factors that we probably don't pay as much attention to is somebody that's under extreme emotional or psychological stress. A bereavement of a close relative, for example, might be somebody that actually needs to be thinking about the sick day rules in that situation. So you have your stress. And that results in production of stress hormones, so growth hormone, glucagon, cortisol, and adrenaline. Those, as I say, those fight and flight hormones. And the reason that you have those hormones in that fight and flight response is to mobilize glucose to enable you to tackle the stress that you're under. But unfortunately, if you've got diabetes, that results in hypoglycaemia. So just now looking at type 2 diabetes, well, you know, with a lot of things with type 2 with diabetes, because people with type 1 are insulin dependent, the intensity of management is more intense than for people with type 2, but you know, there are things that we need to consider for people with type 2 as well. So they need to do testing. Now, some of these people may only be doing very infrequent testing, maybe just testing first thing in the morning or a few times a week. So they need to be aware that if they're unwell, they need to step up that testing. And that they should continue with their medication, even if they're not eating their regular meals. They should be at least contacting their doctor to discuss what they should be doing with their medication. And then, you know, the majority of patients, if they can tolerate it, are probably on metformin. And so, as you know, the concern about metformin is around lactic acidosis, and the risk of that is overstated unless you're very elderly or you've got a kidney disease. But this is one of the situations when you should be considering the problems associated with metformin. And certainly if somebody is dehydrated or is quite sick, you might decide to just stop their metformin temporarily. Encourage plenty to drink. And if things aren't resolving, to seek medical help. So for type 1 diabetes, it's a little bit more intense. So they need to be aware that they need to increase the frequency of their testing up to maybe 2 to 4 hourly. And if their blood glucose levels are elevated, and it's debatable where you should put that line in the sand, but certainly if their blood glucose levels are above 15, some would even say 11, they should be looking at testing for ketones, and we'll talk a little bit more about ketones later on. And what they need to be aware of is that they are completely dependent on insulin, and they should never stop their insulin completely. Now, so they should continue with their long-acting. If they're not eating, they may not need to bolus for their meal, but they will need to be correcting for those high blood glucose levels. And even, I was thinking about this when I gave this talk a couple of years ago, talked about correcting for high blood glucose levels. But I didn't mention this term insulin sensitivity factor or using a correction factor. But even in the last couple of years, people are much more au fait with using correction factors, thinking about their insulin sensitivity. And certainly all of the children, adolescents coming through, it's just second nature to them when they're thinking about managing their diabetes. So a lot of them will have a correction factor. They'll know how much insulin will drop them by how much. For people that, so when you're thinking about insulin sensitivity factor, I don't know if Bridget already spoke about this, but you say you're on a total of 50 units. You divide 100 by 50, so your 1 unit of insulin will drop you by 2. If you've got a total daily dose of 25, 100 divided by 25, your correction factor will be 4. But for people that aren't used to using an insulin sensitivity factor, something else that you could recommend to them is working out their total daily dose and giving 5 to 10% of that as a bolus to help correct. The other thing to be aware of is that when you've got higher blood sugars or when you're ketotic, or both, you're actually going to be more insulin resistant. So what the ISF that you might normally use will be underdosing what you need to do. So the recommendation is that you would give yourself, if they've got ketones present, they would give themselves an additional 50% on top of their normal ISF. So if they've calculated their normal correction to bring their blood glucose levels down to their target level was 6, they'd want to add on an extra 50%, so they'd give themselves 9 units. So that's thinking about the insulin, but there's the fluid side of things as well. So it's important that they keep up their fluids, and obviously if their blood glucose levels are elevated, you're wanting to use sugar-free fluid, so water or diet fizzy. But if their blood glucose levels are less than 11, somewhat counterintuitively, you might say you will want to give them some sweetened drink, so a diluted Powerade, for example, or diluted juice. Because they will need some sugar. And that also enables you to give them to give themselves slightly more insulin in order to clear those ketones. And you're talking about drinking a reasonable amount of fluid, sort of 500 to a litre every 2 to 3 hours. And the other key thing is to actually make sure that, that for the type 1s that they let someone know that they're not that well, because from going to having feeling a bit off and your blood glucose levels being a bit high to DKA can actually happen pretty quickly, and so it's important that there is somebody that's aware that they're not well and keeping an eye out for them. And things that they should be aware of, that actually things like this is an indicator that things aren't going so well and they actually need to get some help. If they're continuing to vomit, so that's described as 3 vomits in 2 hours. If they've got significantly elevated ketone levels on the blood testing that isn't responding to that intensive insulin and fluids. Blood glucose levels aren't improving, significant infection or fever, rapid breathing or abdominal pain. Why are we worried about that? What might that be an indicator of? Yeah, it's an acidotic. So the Kussmaul breathing is that sort of air hunger breathing that you get when you're acidotic. So, those sort of signs would be an indicator that you're needing to seek some medical attention. So we talked about the necessity for ketone testing. So anyone with type 1 diabetes who's had previous DKA is eligible to receive ketone testing strips. You can prescribe 2 boxes at a time, and similarly they can have an opt-in meter prescribed for them. And so it's relatively normal to have low levels of ketones, and certainly anyone on a low-carb diet will have some ketones present all of the time. 0.6 to 1.5 is a little bit borderline, but anything above 1.5 needs for the person to be actively trying to manage that with fluids and insulin.
How often do I test that?
So when their blood glucose is above 15, they should test for ketones. If they're normal, then that's fine. Yep. If they're normal, that's fine. If they're not, they should try and treat that with fluids and insulin and then retest. And if they're not coming down, that's when they need to seek medical help. And it's a good idea, especially in New Zealand, where we're possibly prone to having significant events. I was looking for the right term. It's a good idea to have some sick day supplies at home. So most of our type 1s are used to stockpiling a little bit of insulin, but it's actually important for them to be thinking about this sort of stuff as well. Some still water. So it seems counterintuitive, but having some non-diet fizzy drink or fruit juice or whatever you want to use, some soup or some ice cream, something that's easy to digest. And then making sure they actually have some blood glucose monitoring strips and ketone test strips, and that they're actually in date. So what we tend to suggest is that people rotate them through their emergency box, so that when their own supply runs out, they actually take them out of the emergency box and replenish with some new ones. Similarly with their insulin, they're doing that from time to time. And the other thing that's useful, I think, and I meant to bring them along, and I got here and realised I haven't, but we have a little card that just goes over for people what they should be doing when they're sick. You know, advice about how much insulin to give, remembering to increase by 50% if they're ketotic, advice about non-sugary drinks if their blood sugars are high, but using diluted sugary drinks when they're lower. So, and just giving those bullet points of when should you be asking for help, because you know when you're unwell, your brain's not functioning so well. So it's useful to have something that they can easily refer to. So we're going to move on to a couple of case histories. So Lisa is a 24-year-old. She works full-time as a PA. Relatively recently diagnosed as type 1, so she's just kind of still getting to grips with things. Is on Lantus once a day, and then she's having Nova Rapid, which is adjusting dependent on the carb content of her meals. Has been previously pretty athletic, playing netball and going to the gym twice a week. But since the diagnosis of her diabetes, she's just not been feeling great, and so hasn't been doing as much as she would have liked. So she's developed some DMV following a work function, and because she wasn't keeping any food down, she's discontinued her insulin, and her current blood glucose is 14.2. What would you suggest she does? Sorry, carry on with the Lantus, yep. Yep, so don't stop her insulin, and explaining to her that she's dependent on insulin, so she does need to continue with some insulin. Sorry? Fluids. Keeping up fluids, yep, absolutely.
Tell her friend that she's sick.
Yeah, let somebody know that she's sick.
Test it regularly.
Yeah. Yeah, so she needs to step up her testing, absolutely. Okay. So yeah, so as you're saying, she needs to continue with her insulin. See if she's able to drink. She had DMV, so if she's able to keep up her fluids, and hopefully we can manage her at home. If she's got significant vomiting, she probably is going to need to come into hospital for some IVs. As you say, increase the number of testing, and if her blood glucose levels remain elevated, doing some ketone testing. And yeah, some regular contact. And then, in the longer term, you need to be thinking about developing a sick day management plan. So somebody like Lisa, we talked about having a supply of a sweetened drink at home, testing blood glucose levels regularly, some advice about what to do with her fluids, advice about ketone testing. And the fact that if you are positive, that's probably a reflection that you're more insulin resistant, and you're going to need to increase your insulin. Some advice again, as I said, of when to be asking for help. And then this is an important point that's not really strictly relevant to what we're talking about today, but for somebody that's quite active and sporty, just some advice about what's a good blood glucose level for exercise. So if your blood glucose is elevated and you start to exercise, you're actually going to increase all of those, depending on how intensively you're exercising. But if you're doing relatively intensive exercise, you're potentially increasing all of those stress hormones, which, as you know is going to increase those blood glucose levels further. So we tend to recommend for people that actually before embarking on exercise, they need to have blood glucose levels at least less than 15.
Can I just ask a question?
Yeah.
At the beginning, you said if they've got ketones, then you'd increase it by 50%. And yet on her sick day plan, you said
It's 10 to, it says 5%, yeah. So I apologise because I did the talk in two different bits. So it depends a little bit where they're at. So 5% is a minimum. If they're higher or they're not responding, then you might actually want to increase it further.
Thank you.
So just moving on to the second case. So this is a slightly different scenario. So Louise is a 62-year-old woman. She's had type 2 diabetes for the last 12 years, but only relatively recently started on insulin in addition to the metformin that she was on. And on a reasonable dose, probably the maximum effective dose, I'd say, at 1 gram BD. We often don't get people on such a high dose. They don't tolerate it at that sort of level. And so during, while she was being started on insulin, the practice nurse that was looking after her took the opportunity to talk to her a little bit more about a sick day plan for her. And so she was given a little bit of Novorapid or Humalog, rapid-acting insulin that she would have at home, that if her blood glucose levels were going high, she would actually be able to actively manage that if she needed to. Because the difficulty with the mix is if your blood glucose is high, you can't use that to adjust your insulin because you've got both the long-acting and the short-acting component. And some advice was given to her about what to do with her metformin if she was unwell. So over the last few days, uncharacteristically for her, Louise has noticed her blood glucose levels are much higher. She's normally sort of ranging between 7 and 10, and that they've been between 15 and 17. And she's just phoning up to find out what should she do about these higher blood glucose levels. So what would your advice be to her?
Does she feel unwell?
Yeah, so that's right. So looking to see whether there's an underlying cause. You know, is she otherwise well? Other thoughts?
Is she rotating her side?
Yeah, making sure that there's not a problem with absorption. Absolutely.
Has she been started on any other medication?
Mm-hmm. Is there something else interfering? So those are all good things, sort of looking at the possible cause for why she might be running a little bit high. So I think that's
stress, like emotions.
Yeah, exactly. Yeah. So that's all. Yeah, that's all good. Looking at causes. So what about management of the? So that isn't any obvious cause. She's been feeling a bit under weather. Maybe has a little bit of a viral illness. What would you advise?
I want to know when during the day her blood glucose was up or down. You know, is it consistent across the day?
Yeah, it's been consistent for the purpose of the case. Yeah, consistently above up. Yeah, so you might suggest about increasing her dose of insulin. How much would you suggest increasing by? And there isn't any right or wrong answer to this.
10%?
Yeah, 10% is a good place to start. Yeah. So for her, that would be sort of a couple of units, wouldn't it? So, anything else you'd advise? What about fluids? Yeah, well, you could check the meter. We try and we try and reassure patients that their meters are fine generally, because there's as you know, a lot of distrust of the meters. So in general, we try and reassure them. But yeah, no, that's a fair point. We certainly could look at that. What about fluids? Yeah, we want to make sure that she's maintaining reasonable amounts of fluid, don't we? So yes, has she got any symptoms? So generally people become symptomatic at about 12. Above 12 is when people would generally start to develop some symptoms of hypo. What sort of symptoms are we talking about when we're talking about symptoms of hypoglycemia? Yeah, peeing a lot, yep. Feeling thirsty, tired. Some people will get, especially if it's prolonged, get some blurred vision as well. Looking for an underlying cause, as you said, infection, problems with sights. Any changes in activity or diet. And just inquiring, is she able to keep things down at the moment? What do you think she should do with her metformin at the moment? Yeah. So I think if you're concerned, just stop it temporarily. And so the issue with metformin is that it's excreted by the kidney, so it's not a poison to the kidneys. It's sometimes it's something that people think. It's not a toxin to the kidneys, but it's excreted by the kidney. So if the kidney function is off a bit for whatever reasons, because someone is dry or other reasons, that's when you can get a build-up of the metformin, and that's where the risk of lactic acidosis comes from.
If you did discontinue the metformin, when you went to reintroduce it, do you build it up again slowly, or do you go back at the original?
I think it depends a little bit on the person. Some people seem to just be absolutely fine with metformin. I'd say those were more unusual. So you might want to just introduce it cautiously, but it's really guided by the person and the side effect profile that they've been getting with it. So in summary, for both type 1 and type 2, if they're unwell, they need to be stepping up their blood glucose monitoring, particularly important in type 1. And if your blood glucose levels are continuously elevated, to do some ketone testing and act on that. There's no point in doing the testing if you're not going to then. Your people need to understand what the ketones mean and what they need to do about that. So making sure that people have a good understanding of that. Fluids are important. People that have got high blood glucose levels can become dehydrated relatively quickly, and that contributes to the issue. So maintaining a good fluid, and not just because people aren't eating, it doesn't mean that they don't need insulin. And so and explaining to them the necessity to continue. Okay.
Thank you. Is there any questions for Elaine?
What's the most oral rehydration solution, like gastrolite or in that first case?
Yeah, I think
sugar-free fluid is greater than 15, which will always sweeten.
Yeah, gastrolite would be a good option for people in that situation.
Depending on what would, so you assume it was a filled with sugar in it, so it's for. You've got
so it would be people that have got lower blood glucose levels, because it does have sugar in it, so you do need to, and you might want to dilute it a bit more as well, but it would be for people that have got the lower blood glucose levels. When they're high, you might just want to give some just normal salt in some water. Not very palatable, I know, but sure.
I'm a pharmacist, and sometimes I see people on like glipizide or glipizide with insulin. Is that?
So there's a school of thought. So that we often see people on metformin with insulin, obviously because metformin helps with insulin resistance, and therefore you can get away with a lower dose. And so most of my type 2s who are on insulin will, if they can tolerate it, will be on metformin as well. The thought with the insulin and the sulfonylureas is that the pancreas, for people who've got high blood glucose levels, the pancreas just kind of stops. This is my naive way of thinking. It just can't kind of cope with working in that environment. But if you can bring their overall sort of milieu down with the lantus, then the pancreas may have some reserve that the glycoside or the glipizide can still function. is the idea. It's a and I forget her name, Lorna might remember, it's a Finnish doctor that kind of pioneered this idea. In the longer term, I think those patients are likely to, the sulfonylureas are unlikely to be continue to be effective, but in the short to medium term, when people just start on insulin, things improve. That the idea is that the pancreas can still respond to the sulfonylureas.
And if people were just on the basal insulin, we would use it quite often. Quite often we would use sulfonylurea and metformin with a background insulin. But once people are moved on to
a mix,
short-acting insulin or a mix, we would stop the sulfonylurea at that point. So they shouldn't really be on it if they're on like novel mix 30.
So psychologically for patients, type 2 starting on insulin, you go gently and you take the glucoside off really slowly, otherwise the sugars go up.
Yeah, there's that. But there's also kind of not giving them, but also explaining that this is actually what we expect. This is how your diabetes is progressing. It's not something that they're doing wrong. It's a really important message. I think traditionally we use the insulin. If things don't improve, you're going to have to go on insulin. Whereas that's not the message we really want to be telling people. We want to be telling them, you have diabetes. The natural history of this is that you will need insulin. It's not. That's just what's going to happen. It's not because you're failing.